from the Zuventus India Limited, Dr. Bhupesh, Dewan, who completed his MD in Pharma in 1994 from CME Limited. And he carried with him an experience of over 17 years in pharmaceutical industry, and he has spent some time in UK for about 2 years in Seratrodast, conducted several clinical trials, and he will be deliberating upon what is new in asthma management. So I invite Dr. Bhupesh.
Good evening, everybody. I think it is very aptly said that is there something new in asthma management? Today, we all treat that the current medication are not able to fully control the symptoms. So this is a very, very common problem, and uncontrolled asthma remains a very big challenge for us as a medical fraternity. Now, I know interactive session, and we'll try to make it sort of a workshop where whatever doubt you have, we can discuss on the spot, and we'll try to precisely give you a apt answer on the topic. So, having said so, I would say over here, if you have a look, you see, 21st century, what's new in allergy and asthma management. Now, this butterfly gives us some hope, and a fresh look at asthma and allergy management is important from all point of view. Why? Because it's, you see, in case of North America and UK, even other parts of Russia as well as Europe, incidence of asthma is extremely high. That is above 10%. Some places goes more than 15%. But in India, we are definitely lucky because the incidence is not that high. It is like 2.5 to 5%, depending upon the area. It's very easy to say in rural area, incidence is lesser, whereas in urban area, the incidence is much higher. So the range is 2.5 to 5%. But still, if I consider 1.3 billion population, what is the number of all these patients? It's huge. It's mind-boggling number. And let me tell you something very interesting about it, that 62% of all these asthmatics, they are uncontrolled. This is startling revelation which we got during 2008. And this paper was published, in European Respiratory Society. Though the study was conducted in Pune, a very huge study. Okay. Now, once we are saying that it is uncontrolled and the problem is so enormous, what are the mechanisms? What are the mechanisms which are causing this problem? The basic, of course, asthma is an inflammatory condition, rhinitis is an inflammatory condition. What solutions do we have? Even inhaled corticosteroids, they do not control the condition at high doses also. And we say, okay, inhaled corticosteroids are safer. We have bought over, this idea has been sold to us so well. But as the science advances, we all know that still this affects the HP. The hypothalamic pituitary axis is definitely affected, and the factors which are responsible, they range from your race to the phenotype. This phenotyping of this problem was very well recognized lately, and by now we know that neutrophil positive phenotype is extremely high in resistance towards inhaled corticosteroids. Similarly, eosinophil positive phenotype, why? Because the basement membrane per se becomes so thin and so hyper-responsive that the inhaled corticosteroids also do not cause enough of the relief. Lucky are those patients who get the relief. Not only that, even LTRAs, you had been treating all these guys. LTRAs, LABAs, long-acting beta-agonist agents, SABAs, which we always consider and presume it to be that it's the best answer. they are also not able to control. And this is everything documented from day-to-day life. So targeting anti-inflammatory therapy from various pathways is extremely important. Now, thromboxane A2 remains one of the major unidentified part in case of asthma. I tell you, even in the second year when we studied about thromboxane, we always associated this with the clotting. We knew thromboxane A2 is involved in clotting mechanism, that's it. But thromboxane A2 is a very potent bronchoconstrictor, and that is very well proven in multiple trials, and we are all aware of it by now. But the most interesting part over here is that what is the organ which is producing thromboxane A2 in the maximum quantity? This is the engine lying in the lungs. It's a huge area. Whole of the lung parenchyma is able to produce thromboxane A2 in large quantity. Studies have been conducted. We found that those patients who are normal, they produce very low quantities of thromboxane A2, but whereas asthmatics, they produce a huge difference, like 4 to 5 folds higher thromboxane A2 as compared to normal. So this was the point why an agent was found out to counter thromboxane A2. Second thing is that in case of asthmatics, prostaglandins, yes, they are also very important. We have friendly prostaglandins I2 and E2, but we have these difficult prostaglandins, that is D2 and F2 alpha. They are also very potent bronchoconstrictors. But what does thromboxane A2 does? It is not only that it is causing bronchoconstriction, it also is involved in the modulation of the cholinergic response. Acetylcholine, is the major neurotransmitter in parasympathetic pathway, and we give ipratropine bromide-like product for countering that to relieve the patients. But in this case, thromboxane A2 is the one through the intricate mechanism which modulates the release of acetylcholine in the neurons. This is very important to understand. Second, whenever there is a vasoconstriction induced by thromboxane A2 excess quantity being produced, what it does, it causes microvascular leakage. So somebody said that if you want to say a patient is asthmatic, normally we say we challenge with methacholine, we have so many other ways, we measure spirometric methods, but if you want to say a patient is asthmatic, measure is albumin in the sputum. Now what is the relation? Albumin will trickle in the sputum because microvascular leakage is causing that thing to come into sputum, and that's how it is coming out into the presence in the sputum. So microvascular leakage is the positive factor of thromboxane A2. It opens up the gaps. Plasma leakage. It increases the mucus secretion, another big trouble. Not only that, it also stimulates the mechanoreceptors. Once mechanoreceptors are stimulated, cough threshold is lowered. Cough threshold is lowered, person is helped. That's a major reason why asthmatics keep on coughing a lot. Second thing, the quality of the mucus becomes different. It becomes more tenacious, more viscous, and patient is unable to expectorate that time. Along with that, mucociliary movements is reduced. So, multiple factors affecting the same disease. Next point, if you see, it causes airway hyperresponsiveness. I will come to this point a bit later. And it thickens and remodels the airway wall. You know why? Very interesting mechanism. This molecule is responsible for the stimulation of fibroblasts. And fibroblasts, they release huge amount of growth factors. Those growth factors help in stimulating smooth muscle proliferation. All these things, they lead to the thickening of the basement membrane as well as the proliferation of smooth muscle. So there is a remodeling of the airway, and if this condition is not controlled, asthma continues into COPD. And various other things which are positive agents for COPD, but thromboxane A2 is one of the primary reasons for induction of COPD. So if I look at this, it is very simple that thromboxane A2 releases acetylcholine neurotransmitter, it causes bronchoconstriction, vasoconstriction, activation of eosinophils. They release, this is again a very intricate mechanism. Eosinophil releases lot of chemotactic factors. They attract more cells, okay. There is release of factors which stimulate CD4 cells. CD8 is reduced, CD4 is increased, and CD4 is releasing three major interleukins. That is interleukin 3, interleukin 4, and interleukin 5. All these are similarly huge potential for chemotaxis. So vicious cycle sets in. More and more eosinophils start penetrating the parenchyma. Now, if we look, if somehow we can control this factor also, it is of great help to the patient, because eosinophils are not the only ones. Neutrophils carry equal importance, and they are releasing chemotactic factor for neutrophils also. Then increased microvascular, leakage, increased tracheal mucus secretion, viscosity we discussed, and enhances airways mucosa. So fine, we now have got a little bit of trace of what thromboxane is doing, but not satisfied as yet. Because a thing is ingrained in our mind right from the beginning that everything is the resultant of phospholipase. Phospholipase or phosphocholine, which is part of the cell membrane of every cell. There, when the phospholipase A2 acts, arachidonic acid is produced, and now it depends upon, since arachidonic acid is available, whether it is cyclooxygenase or lipoxygenase. Depending upon that, we get the prostaglandins or we get the leukotrienes. But this story is half told. Nobody tells you what happens to leukotrienes. What do they do? Are you aware that leukotrienes hardly have any direct effect on the lungs? They have effect on various other cells which induce the further mechanisms to produce the effects which are known to be produced by leukotrienes. Now what are those? Leukotrienes, they stimulate thromboxane A2 producing cells. Which are those cells? Mast cells, present in lungs in huge quantity, alveolar macrophages, eosinophils, platelets. All these cells will start releasing thromboxane A2, and this thromboxane A2 then acts on the thromboxane A2 receptor processing cell. Now what is this I am talking about? I am talking about a similar mechanism what we heard when PPIs were launched. We all knew about H2 receptor antagonists. We all knew about anticholinergic agents. But when ultimate blockade, PPIs, fine? Similar analogy is over here. That whether it is an allergen or it is endothelin, which is stimulating, or endotoxin, bradykinin, platelet activating factor, any of these stimulants, there are more than 50 different chemoattractive stimulants, and they induce the thromboxane A2 producing cells to produce further thromboxane A2. Mind it, this thromboxane A2 processing cell, which I am discussing over here, is so important that prostaglandin D2 and F2, which are again injurious for asthma, they also act on the same receptor. This is extremely important to block this receptor if you want to really control asthma. Okay. So as a result, what happens? Excess mucus secretion, ciliary movement disturbed, bronchoconstriction, permeability increased. Fine. What does the guidelines suggest us? Our body was formed that various chest specialists are treating patients differently. Why can't we have a common path? But this path has never been achieved as yet. I have been regularly interacting with Gina guys over there, and lot of email communication we keep on having. With the latest they said now, Gina guidance is getting updated again, though it got updated last December only. But again it will be getting updated very soon. And on 15th of February, they other which are controllers. That's the crux of Gina guidance. Now why? Because relievers are the one which are short acting, they are firefighting. So you give them for only a very small time for a quick relief of severe symptoms. And these drugs are like rapid acting beta-2 agonists, inhaled anticholinergic agents like ipratropium, short-acting theophylline, short-acting beta-2 agonist, all these are firefighting mechanisms. But for long action, you depend upon corticosteroids, immune corticosteroids form systemic, LABAs, leukotriene modifiers, sustainable theophylline, chromones, even IgE therapy. But they suggest one thing very clearly, that when a patient is not responding, keep on adding or keep on increasing the dose of these controllers. But sooner the patient gets controlled, please start reducing it so that his tolerance profile, his side effect profile is reduced and a normality is maintained. So this is the best match. Increase and then reduce, right? There we have to maintain. But the first step remains, you should be depending more upon the controller mechanism. A week, 10 days, a fortnight is sufficient for relievers. Immediately, start with the controllers along with. Same way, Japanese guideline has suggested that you depend upon controllers more, and they recommend Seratrodast as one of their major controllers. I will discuss it a bit later. Now we understood that thromboxane A2 somehow has to be inhibited. So one will say, why can't we simply give a thromboxane A2 synthase inhibitor, which is an enzyme? Yes, we can give. We can reduce the production of thromboxane A2 by giving a synthase inhibitor, like there is a drug called as Ozagrel. Ozagrel was introduced in 1992 in Japan, but was not successful. Why? Because PGD2 is still there. PGF2 is still there. The receptor of thromboxane A2, which is common for all these, this is getting stimulated. So it's not getting controlled. The best bet is to give a receptor blocker. So that's how receptor blocker, that is Seratrodast, was introduced. That's the crux about the whole situation. This chart will give you better idea that prostaglandin H2 is available. If you will block the synthase to form thromboxane A2, others will keep on forming and the receptor is getting stimulated continuously. This is very important aspect. This is called as synthesis redirection. Okay, so now once we come to the receptor blocker, what is this molecule? It's a beautiful molecule. Nature's molecule. How? It is just a replica of thromboxane A2. So whatever is the structure of thromboxane A2, this molecule mimics that. And that's how it is able to fit in absolutely in the place where it is required. And it is a quinone derivative, benzoquinone derivative. It is not a quinine derivative. It's a quinone derivative. I'll tell you why it is important. Seratrodast does two main things. One, blocks thromboxane A2 and blocks PGF2 and D2 because all of them are working on the same receptor. Now you can ask me, are there different receptors available? Are there receptors for platelets different, placenta receptors different, and yes, there is a huge amount of thromboxane receptor heterogeneity. And Seratrodast is specific for lung. It is specific for lung tissue. If I look at this slide, it's very interesting to tell you that see, there is an early phase of asthma where we require firefighting mechanism. Here if you start controller immediately, what happens? That your requirement of the other agents will reduce. Because thromboxane A2 is the major culprit, it is getting blocked by Seratrodast. It will prevent the late phase where eosinophil and neutrophil are causing all this noxious attack. You see, what happens? Eosinophils they release major basic protein, very dangerous thing. ECP, eosinophil catechol protein, EPO, eosinophil peroxidase, halides, hydrogen peroxide, platelet activity factor, all these things, what they are doing, they are injuring the airway epithelium. And as a result, irritant receptor exposure is there. And that's why we land up in airway hyperresponsiveness. Mind you, if we give Seratrodast, all the three are taken care of. So it's one of the very, very major thing that's an known pathway which we are now highlighting, and this is going to be the future. You see, if you give Seratrodast, which is available as an 80 mg tablet, within 7 days, steady state concentration is achieved. It starts building up on the day 1, but 8 days full levels are achieved. The effect starts on the day 1, but we always say that if it's an acute stage, acute asthma, you start Seratrodast, but along with some other agent, at least for first 1 week, because that's a firefighting time. You don't have to take a risk on that aspect. This molecule is extremely good in its half-life. It's having 25-hour half-life. So once in a day is sufficient. Now question comes when to give. You can give it in the evening hour. Why? Because in the evening hours, asthmatics, they are more prone to have bronchoconstriction. That's why the beginning, when you start the medication, start in the evening hours. But then, after a week's time, when the levels are built up, you can give it any time of the day. There is no problem. Now, this molecule is very highly protein bound, more than 99%. And you all remember your pharmacology days that aspirin is one of the major caution whenever there is a protein binding thing. We say that please be cautious when you are giving aspirin. Now, we have to be careful about aspirin when we are giving Seratrodast, because free dose of the Seratrodast will be raised and can cause problem. But what dose of aspirin? Aspirin is having 3 doses. One for platelet inhibition, that is small dose 50 to 100 mg. Second, which is used for antipyretic activity, which is up to 600 mg. And then anti-inflammatory activity. We are referring to the anti-inflammatory activity because that has to do with the arthritis or something. There you have to be cautious. You have to adjust. Whenever a patient is taking aspirin, 26% of the Seratrodast concentration is raised. Right? So you have to. So the effects of Seratrodast relieves airway hyperresponsiveness. Patient doesn't cough. Patient's mechanoreceptors are subdued. Decreases airway inflammation. When this is done, the ciliary movements increase and the sputum is expelled out better. Plus, it also thins out the mucus. So the consistency or the quality of the mucus is changed. It reduces viscosity and quantum of sputum, increases cough threshold. So patient doesn't cough much, decreases microvascular leakage, and it's good for early as well as late airway response. Indications. Indications are asthma management, allergic rhinitis, and adjuvant in COPD. But there are several others. Smoker's cough. Extremely good for smoker's cough. In fact, February 13, a paper is published. How it could be good for smoker's cough. Also, it is useful in other indications. It can reduce the dose. What are other indications? Now, in adults, you can start with 80 mg once a day. But you can raise the dose also gradually. Say, always any drug's dose should be gradually raised, especially when it's a controller, at a monthly interval. Don't increase it at a weekly interval, even the patient keeps on insisting. So maximum up to 320 milligrams. You can combine Seratrodast with any given other agent. There is no drug interaction of that kind other than aspirin, which we have discussed, and long-term studies are available. But there is a caution. You must give this drug in elderly patients at a lower dose. Why? Because their mechanism of metabolism starts slowing down, and we have seen that 40 mg would be good. Then you ask me, who is old? Nobody is old. So that's a very good question. So I would say that age where government gives you 50% subsidy on railway tickets, that age you consider to reduce the dose by 50%. This is simple understanding. So 60 years or 55 years is the age when you can reduce the dose of Seratrodast to harm. Okay, reactions. It's very important to highlight this word generally rare, but if present, it may range from A to Z. Why these are mentioned? This is as per the internationally conducted good clinical practices. Now, these clinical practices, they know each and everything, whatever happens. But just like Montelukast, the way Montelukast raises the AST and ALT levels, this drug can also raise in less than 5% cases AST and ALT level. So in those cases, you can monitor at a monthly interval or so. My simple question to you, how much raise in AST, ALT or liver parameters is dangerous when we say now patient requires cutoff dose? Anything which is more than 3 times the normal level. So for example, AST, ALT is 40 units, the upper limit. If it goes to 100 and above, then we have to be cautious. This is a reversible phenomenon. The patient starts reversing it. It's an initial response which liver shows in some of the patients. Next, of course, I will never touch any drug for pregnancy and lactation. You all are aware. Plus, this drug has been shown to have some fetal abnormalities. The septal defect, in the heart, the septal defect was found to be affected, like in young animals. And pediatric, we don't give this drug. Contraindications, hypersensitivity. This is a new drug at this moment, so that will come later. Patients with hepatic failure, because this drug's metabolism is liver, through liver, so we have to be cautious in hepatic failure. My point that aspirin, whenever you're giving, the concentration over 26% higher, so you have to be careful. A bit of tidbits. I am really very proud that this drug is purely Indian. 100% Indian drug. This drug, we are producing, even the raw material internally, nothing is imported. Not even a single dollar is going outside. Everything is in-house. And it was helped us, for us by ex-NCL director, Dr. Mukund Gurjar. He was instrumental in making this molecule happen. So this tidbit I just wanted to discuss with you, that this is a national pride. Now before we went into clinical studies, we thought it's prudent to pull out the Indian gene pool and see whether this drug has a good match with that or not. So we did molecular modeling studies. I'll show you something which you will be really liking. This is a 3D structure. You see, this is the Indian gene pool's thromboxane A2 receptor, and this is the molecule. So we did that fitting. It is absolutely fitting that particular receptor, thromboxane A2 receptor. So the conclusion of this was, now this is a bit like lighter over here. Actually, this is showing how each and every amino acid is getting interacted with the branches of the molecule. But the thing remains that this particular pharmacophore study which we have conducted, it gives us only one message, that Indian population is well suited to consume Seratrodast for optimal therapeutic purpose. Now I go to the clinical efficacy. So what we planned that we will do kinetic study as well as dynamic study. In the kinetic study we simply did what? That since this drug is available in Japan since 1997 as a brand called Guanica, we compared our drug with Guanica to see how is the kinetics happening. So kinetics just matched, and that's how this drug was shown to be bioequivalent with a similar kind of half-life with a range, and this drug can be given once a day because of this particular thing. Please look at this. This is 5.38 is the Cmax, whereas after 1 week's time the Cmax goes to 8, right? So you can start expecting good results, but the maximum optimal results start appearing after 1 week when the steady state concentration reaches. Steady state means when the intake and outgoing of the drug, absorption and excretion match each other. Now we come to a clinical point. In the clinic, we simply decided to conduct 3 things. Because this drug was very well studied in Japan. But we thought like, we'll do some good study on this. What we did, we stabilized the patients for 14 days on inhaled corticosteroids, first of all, so that they come on the baseline. Then we added in a double-blind, double-dummy, randomized trial. What is this double-dummy? Each patient was receiving active of Seratrodast and dummy of Montelukast, active of Montelukast and dummy of Seratrodast. So this is how patients were randomized on a number of 235, out of which 205 patients completed because of some of them were lost to follow-up. And we studied 3 things. 1, clinical symptoms, 2nd, spirometric parameters, and 3rd, sputum and mucosal clearance. So in case of clinical symptoms, we said, okay, wheezing, shortness of breath, expectoration, cough and chest tightness, these are important things to be studied on. And there was, both the drugs, they had some improvement over the baseline. But in case of lung function spirometry parameters, PEF, FD1 and all these parameters were improved. But glucose test is very important. This glucose test tells us what is the tenacity of the mucus and eosinophil tetanic protein and albumin level. All these things are better, but my concluding slide to you is that where this scores much better over, he said, first of all, in long term it scores better. Second, over module class, it can increase PFR much better. TCP and albumin are reduced much better, and tolerance wise it is very good. So these are the results where the significant levels mentioned. So I would like to skip because we have just discussed this. I'll come to the important aspect now, and that aspect would be the international studies. There are a lot of studies, comparative studies available with Montelukast, Zephyr-Lukast, Pran-Lukast and others. Everywhere it is shown that Seratrodast is producing great result. Found only line over here. It is something startling that it can reduce the requirement of inhaled corticosteroids, which was proven in 88% of the patients who were consuming inhaled corticosteroids. Their dose requirement, their breakthroughs, they were reduced. 88% of patients, which is a very high number. Okay, in allergic rhinitis, again it is very important because it blocks everything, including early phase and late phase. So it's a comprehensive controller of allergic rhinitis. Again, lot of studies are available comparing it with histamine, antihistamine, and imperial allergic rhinitis. So COPD also I told you, it can affect the deteriorating state. It can arrest the degeneration of the lungs and improvement in respiratory distresses observed when you start Seratrodast. Concluding slide. Improves clinical symptoms, lung function, decreases sputum and albumin glucose and ECP, decreasing the amount of sputum, improves nasal mucosity clearance, facilitates vascular and bronchial smooth muscle relaxation. Pride of India, first drug which got approval just in last year December. There are studies available internationally, more than 5,000 patients. We are starting a trial over here involving more than 30,000 patients. We are going to conduct this post-marketing study immediately. So this drug is nice. But before I say thank you, this is an interesting Olympic gold medalist says, don't ever let anyone tell you that you can't do something because of asthma. As long as you can communicate with your doctor, you can live a normal life. I think it is a very apt message this guy has given, because asthma is controllable, but still we have uncontrolled asthma. So I think this is a new drug available with you, and I welcome any of the suggestions which is coming from the audience, and we can discuss it now. Thromboxane A2 is an autotype. And how will we measure the levels of thromboxane A2? A good thing is that this molecule gets converted immediately into thromboxane B2, which is having a stable life in the body. It is appearing in urine also, it is appearing in blood also. So there are ELISA kits available to measure the level of thromboxane B2. That's how we measure the indirect levels of thromboxane A2. And this has been proven beyond doubt that these 5 conditions I told you, they are the levels of thromboxane A2 are.
Is the dose same for renal allergy?
Yes, 80 mg per day per day.
Where would you? Sorry.
Now, in case of asthma, you can raise it to 320 mg. Whereas in case of allergic rhinitis, you won't require to go beyond 160.
Where would you position this molecule in the management of asthma?
First is uncontrolled asthma. So when you find that patient is not responding, you can simply add on this drug. Number 2, sir, when you find a new patient coming to you, you start with whatever drug you want to start along with Seratrodast. you can later withdraw the drug, patient will be controlled best on the Seratrodast alone. Because
Do you place it before inhaled corticosteroid?
no, that I never say at this stage. Experience will tell us. But we have seen that after 6 months of therapy with Seratrodast, the requirement of inhaled Seratrodast.
So as I understand, those patients who have failed on inhaled corticosteroid, where you
Yeah, first, let's focus on the uncontrolled patients, where your patient requires help. Secondly, in those cases, you simply start with discharge along with the removals for a week or 10 days or more time, just to control the initial situation, and then carry on. But this drug is not recommended for acute asthma. To treat acute asthma per se, as a single agent, you have to start this drug in acute asthma. For mechanism, you can start it as alone. But for acute asthma, you must combine it with inhaled corticosteroid because it takes around 1 week's time before the optimal response starts coming in.
So what was your study cast? What was the study design? Or you said that all these patients were stabilized on inhaled corticosteroid?
Yes. See, these are the known asthmatics.
Yes.
So they were weaned off any other drug and they were kept for baseline purposes on inhaled corticosteroid. Now this is an internationally evaluated above. We added Montelukast or Seratrodast in it.
Why did we add? If the patients were already stabilized, why did we add?
Because this was
With
wrong.
an intent to reduce the
No.
dose of steroids or what?
No sir. Because it was the steroids are withdrawn. Patients are controlled now. They are not in acute phase.
Okay, so inhaled steroid was withdrawn.
Yes.
Okay.
That was the baseline. So now what we can do beyond the baseline, that is what we have seen, that how it improves. If the inhaled corticosteroid continue, then we won't be able to find the effect of.
That's what I was thinking.
When we conduct the clinical studies, they are very controlled studies and they are expensive, right? Are available, right? But patients in Japan are using it for since 97 it is available. We can imagine it's a growing market over there.
But you haven't shown us the 2 years follow-ups.
I showed you. In fact, I saw some movement happening, so I thought, let me cut it down a bit, otherwise it will go too long.
We will only be convinced with the clinical data.
You are sure, sir. There is a ton of data available. So I am just first of all bring you. Yeah, over here, for example, this is one study, measure of dose of inhaled budesonide and propionate when used over a period of 9 to 24 months.
We are the person who are seeing the patients who are potentially asthmatic, energy granulated patients. Our attention should be to treat the patient initially, so that the asthmatic patient, so the patient may not develop asthma.
Yes,
That is
sir.
a very broad thing to discuss. But whenever we talk about the trials, asthma is basically allergy. We are talking about the trials done elsewhere. Okay? We are living in our surroundings. The surroundings with some allergens causing some allergy. Why we should not take initiative from your side to do some trials in India? That will be like. We always try not to talk about the trials other countries which may not work in our surroundings.
I fully agree with your comment, first of all, and I thank you for that. Now, there is a huge elite group sitting in front of me who are all are asthma specialists over here, a lot of them. You are aware that asthma is more of a syndrome rather than a single disease. And there is not a single factor which is involved. There are a plethora of other symptoms or other etiological agents which induce asthma. Right from the patient's genetics, his own environmental factor, his own phenotype, and various other things which are involved. Now, you have very rightly said that we are the people who see allergy first and then patient degenerates into asthma, it progresses down, it goes to chest specialist. This is one of the extremes. This is one of the varieties, right? But there are other varieties where there is no allergy component per se seen. Patient has more of the hypersensitive. The bronchoconstriction happens without much of the other factors which are involved, where we cannot really define what happens. Such cases are so severe, many of those won't respond to high doses of inhaled corticosteroid also. And this is not small incidence, it's a very huge incidence. So your point is well taken. We have to conduct more studies in Indian scenario with Indian allergens, no doubt about that. See, today what we are doing, whatever is available, whatever info we are sharing with you. And I told you right in the beginning that we are going to start trial on 30,000 patients. It's a very huge number. It's going to be a huge trial which we have not conducted annually. Even very few companies have conducted this huge number. We are going to involve a lot of doctors all across India in both the specialties, the ENT specialty as well as in case of chest and the kidney specialty.
Probably that will reduce the cost
Yes.
of the cases of Seratrodast.
Yeah, of course. I understand. That's a very valid point here. Thanks a lot.
Thank you.
Please, Dr. Sujit Kumar.
Dr. Dewan.
Dr. Sujit Kumar is asking questions.
Yeah,
Yes.
yeah. Thank you, Dr. Bhupesh, subject. And since it was easy to understand, so there are more questions.
Absolutely. I like it.
So, just what we have read in half a minute, there are two types of response: early asthmatic response, secondary late asthmatic response. Early asthmatic response is mainly, to be very precise, mainly because of the mast cells, whereas the late is mainly because of eosinophils. Right? Since corticosteroid do not work on the mast cells, do not act on the mast cells, except that hydrochloride that was there. Therefore, it does not act on the early asthmatic response. So, we give it for the late asthmatic response. And for early asthmatic response, we have some drugs earlier in the form of antihistamines, and then give the montelukast. What I just want to say is that we are positioning it at the present time as per the GINA guidelines to be added in uncontrolled asthma. That is what we said. Now, when such a drug, one single drug is acting on both the response, on both the path, early and late, I don't understand theoretically why it shouldn't be used in the first place. Number one. Number two, in Japan it is available for last 15 years. I fail to understand why there is no study to show its efficacy and safety in the children. I fail to understand this point. Then you have compared with montelukast. Now, when a montelukast drug is already available in the market, as far as we as a clinician in a clinical aspect, we would love to have some new drug which we may add along with montelukast rather than replace.
Sure.
Suppose with montelukast we are having some good results in some of the patients. In those patients where we don't have good results with montelukast, we all know that it is variable.
Can you give me some, please?
Why
Because
can't
I
it be
don't
added
Give
with
me-
the montelukast, especially seeing the pharmacology that montelukast is a one pathway, one-hand pathway, whereas this Seratrodast is on another pathway. So if both the pathway which is acting, why not together, and why this study has not been done? Then, yes, inhaled corticosteroids do not act on mast cells, and also it does not act on the neutrophils. Now we have said in our pharmacology lecture that it also acts on the neutrophil. It accumulates neutrophil or whatever. It takes care of neutrophilic response in rare or what we call near fatal asthmatic patients. So if these are so good things with this, so why not it should be used in not only in those patients in which inhaled corticosteroids are not responding, but why it cannot be used as a first place? This is one very important question. Second is, why no study in children despite 15 years old? Why no study out of Japan? And why no study keeping it together with the montelukast?
I think by now, please excuse me, I will try to recover as much and I will keep on answering you much more. I will first come to the basics and ethics of clinical trials. I have been into this field for more than 20 years actually, when I am conducting clinical trials, and I have a stint in England also, where I did huge number of large trials. See, as far as pediatric age group is concerned, every person in this world is extremely sensitive to treat pediatric age group. Then how we come to know or give a drug in pediatric age group? Are you aware montelukast was never recommended in pediatric age group? Any anti-allergic drug was never recommended. Cyproheptadine was not recommended. No drug was recommended in pediatric age group. Then Dr. Sunil Kumar, how come these all drugs are being used in pediatric age group? The simple reason is, the simple answer is, this is called as serendipity. When we come across the post-marketing surveillance studies and we find that say a trial was data was collected from 30,000 or 50,000 or 1 lakh population, and we find 300 children were given drug by doctor who was very courageous and still is reporting, then it gives us some clue that yeah, now a study could be started. This is the way the starting process of pediatric study. Otherwise, the ethics committees, you try taking an opinion for a new drug to be studied in pediatric age group, nobody will permit you, not even the Drug Control General of India, not even the US FDA. So it is, you have to give them some evidence. So what evidence we have? We generally give them, animal, evidence, as well as these findings which we get through various clinical trials, and then we give them the safety data of adults. So once this sort of baseline is formed, then we give them a clue that okay, it looks to be safe, so should we try it? And once they see that okay, the risk-benefit ratio is favorable, they allow it. So it will eventually happen. It is not that we are rejecting that it won't happen, it will eventually happen. But in Japan, they have their own ways, they have their own things. We really cannot comment upon that. Why did not they conduct it? But definitely it will happen over here once we get this huge number of exposure to the patients. So this was the first question. The second part was,
when it is acted on both early and late,
okay.
why not
So that is the very basic and interesting thing which I told, that you can actually start from the day one. When the patient comes to with rhinorrhea, it is a very good drug to control rhinorrhea. You first give it, this drug along with some other drug, because this drug takes some time. It gets accumulated. It is not, see, this drug is having pharmacologically, if you look, this is having a very long half-life, and it builds up slowly. So 7 days